So, as I told you about it's really important how you're going to be able to differentiate between aortic stenosis and hypertrophic cardiomyopathy. So, the first of all, the thing is aortic stenosis is going to present patient population. It's going to present in older individuals, and hypertrophic cardiomyopathy HOCM, because it's a congenital disease, it's going to be able you're going to mostly see people with the age of 20 to 30. So that is how you see the difference in patient population. Aortic stenosis results from gradual calcification of the valve. So patients usually 60 plus with regurg occurring earlier and then developing aortic stenosis. This is not due to valvular issue, it's because of the thickening, widening of the interventricular septum due to beta myosin chain mutation that results in outflow tract obstruction. So most of the things are just the same. So if you decrease so aortic stenosis, if there is less blood flow across the valve, the murmur is gonna decrease in intensity. That is that if you decrease the preload, that is less blood in the chambers, the murmur of the aortic stenosis is gonna reduce. Whereas if you decrease the amount of blood in the chambers, the hypertrophic cardiomyopathic murmur is gonna become louder. Why? Because, so I want you to visualize, this is the left ventricle and this is the right ventricle of the heart. So when it comes to hypertrophic cardiomyopathy, this interventricular septum area, it's really thick, like I just highlighted here. It's really thick to the point that it causes a tendency to cause obstruction. This is the interventricular septum here that I am just highlighting in red, and this is the aortic valve, and this is the aorta that's branching. Due to the thick septum, when there is less blood in the left ventricular chamber, the septum and the mitral valve, the anterior motion of the mitral valve during the systole, they just approximate with one another due to less blood in the left ventricular chamber. That results in outflow tract obstruction. Whereas if there's a lot of blood in the chamber, despite the ventricle being really thick, like I've shown here, when there's a lot of blood in the chamber, that keeps the systolic anterior motion of the mitral valve and the interventricular septum not that much approximated, which results in a better movement of blood from the left ventricle into the aorta. So basically, just what I mean to say, as we discussed, the two exceptions when it comes to murmurs was mitral valve prolapse and the murmur of hypertrophic obstructive cardiomyopathy, that is this one, which basically decrease when there's an increase in blood in the chamber. So decrease preload, what's going to happen? The murmur is going to increase in intensity. Increase afterload, what is this going to do? When there's increase afterload, there is going to be greater left ventricular and diastolic and systolic volume. Because of the greater resistance, a lot of blood, all of the blood won't be able to be pushed out from the left ventricle, so blood would remain. That would gradually result in greater amount of blood being left in the left ventricle. So that is gonna reduce the intensity of this murmur. And how is this? This is the hand grip. I told you guys the hand grip is important. And what happens when there's greater afterload? There is not much speed of the blood flow across the valve, because when the blood is flowing, this is the valve and there's a great amount of back pressure, and this is the left ventricle, and the blood is also flowing from this direction into the systemic vascular system. Due to greater back pressure of the blood, the flow is not that much of high velocity. That results in decrease in the intensity of the murmur. So S4, as I told you, S4 is also termed as S for gallop. It occurs due to left ventricular hypertrophy. So aortic stenosis, that results in hypertrophy. So it's going to be present. Hypertrophy, it's going to be present. So aortic carotid pulses. So you can just assume both are soft and delayed. It's not important. The important thing is what happens with preload reduction, what happens with increasing in preload, and what happens during the hand grip. So these are the important things that I just help you guys to understand. So here's also question: hand grip effects on the murmur of AS. The murmur of AS is gonna reduce because of reduced blood flow across the valve, because there's greater back pressure, HOCM, because of because of increased left ventricular and systolic volume. There's gonna be a gradual increase in the blood left in the left ventricle that would result and impair the approximation of the left interventricular septum and the systolic anterior motion of the mitral valve. So the closure won't be that much because the blood is remaining in the left ventricular chamber. So both of them would decrease. Role of mitral valve on HOCM. This is a really important question when it comes to USMLE as well. Systolic anterior motion of the mitral valve during systole is responsible for outflow tract obstruction in HOCM. The mitral valve gets closer to the already thick septum, which causes the outflow obstruction. Hand grip causes decrease in transvalvular blood flow due to increase in afterload. So these are the important points that if you hammer down, and they're going to be really easy for you to decipher what increases what, which murmur increases and decreases under which circumstances. Supravalvular aortic stenosis. When we were studying the locations of the murmurs, I also mentioned that. Let's come back to this. So I told you A, P, ANP, regurg, T, M, AST, AST, VST. So when I told you if the stenosis is of the valve, the sound is going to be in the second intercostal space on the right side. And if it's supravalvular or root of aorta constriction that is causing the outflow tract obstruction, you're going to be able to hear it in the first intercostal space. So that's why I just wanted to come back to this diagram to show you what I meant by that. It is the second most common type of aortic stenosis, usually referred to congenital left ventricular outflow tract obstruction due to discrete or diffuse narrowing of the ascending aorta. So it's going to be heard at the first right intercostal space, higher than the valvular aortic stenosis murmurs. And one more question I want to ask you guys as well. If the aortic stenosis or the outflow tract obstruction is because of HOCM, where are you going to hear the murmur then? It's going to not be on the right side, it's going to move to the ANP regurg side. ANP regurg area on the left side. So it's all outflow tract obstruction, one on the right second intercostal space, one on the right first intercostal space, and the third one on the ANP regurg area. Patients may also have unequal carotid pulses, differential blood pressure in the upper extremities. This is a really weird finding that you have, that differential blood pressure. Usually differential blood pressure happens when there is dissection. So you get different blood pressure on the left and the right side of the body. The left hand and the right hand blood pressure don't match. And when it comes to differences in blood pressure on the upper extremity and the lower extremity, this happens when there's coarctation of the aorta. So differential blood pressure also occurs in supravalvular aortic stenosis. Patients with significant supravalvular aortic stenosis develop left ventricular hypertrophy. And over time they can also have coronary artery stenosis as an associated anomaly. So this is a high yield point of patients having supravalvular aortic stenosis developing coronary artery stenosis as well. These changes, along with increase in myocardial oxygen demand due to left ventricular hypertrophy, which results from greater force production required to push the blood, can lead to subendocardial myocardial ischemia, which is likely responsible for patients' angina symptoms during exercise. So the takeaway points is the first right intercostal space where you would hear it, a differential blood pressure, so you don't confuse that with aortic dissection. And if even when the patient says that he has chest pain, you might even further confuse it with aortic dissection, but the chest pain can be a symptom of angina. So let's move on to mitral regurg. So mitral regurg can be acute in nature, it can be chronic in nature. So we're going to first discuss the etiology behind mitral regurg. Mitral valve prolapse, yeah, it can lead to mitral regurgitation, infective endocarditis. I told you it can rheumatic heart disease. The initial presentation is going to be regurg, the late presentation is going to be mitral stenosis. Rupture of mitral chordae tendineae from, yeah, papillary muscle displacement or rupture due to MI. So this is also a high yield one. After MI, there's papillary muscle rupture due to the papillary muscle going ischemic and with the fibrosing that can result in mitral regurg as well. So in the mitral regurg in this case, when the papillary muscle are ruptured, would be acute in nature, whereas the mitral regurg in this case, infective endocarditis, rheumatic heart disease, that's going to be slowly developing chronic in nature. So another reason for mitral regurg that is also going to be mentioned is acute decompensated heart failure. When there's acute decompensated heart failure, the heart is not able to push the blood towards the body, and the left ventricular blood volume increases drastically because the blood is not being pumped forward. There is dilation of the mitral valve annulus, the ring that holds the mitral valve. So when there's dilation, that also results in mitral regurgitation that is acute in nature. So clinical features of acute mitral regurg rapid onset of pulmonary edema. Why is there? Because there's no compensation going on. There's mitral leakage, all the blood starts flowing backwards into the lungs, and there's pulmonary edema. Since all the blood is flowing backwards into the lungs, it's not flowing towards the body. So there is also cardiogenic shock because the body is not receiving blood. There's hypotension because the body is not receiving blood, it's going towards the lungs. Acute left ventricular failure because the left ventricle keeps on trying and trying and trying and trying, but it's not able to pump blood, and it overexerts and starts failing. What are going to be the physical symptoms? The three is the blood flows towards the lungs, pulmonary edema, then it starts flowing towards the right heart, then back into the inferior vena cava, so you get jugular venous distension, pulmonary crackles, and hyperdynamic cardiac impulse. So and because the blood is not being pumped towards the body is going to be cool, and the patient is going to have like hypotension, and the patient is going to have shock like symptoms as well. So one more high yield point, when it comes to acute mitral regurg, you won't be able to hear the murmur. Why you won't be able to hear the murmur? Because there's no obstruction towards the backflow of the blood. The valve or the mitral valve is just open like that, so it's a free flowing backflow of the blood. So murmur is heard when there's turbulence, when there's obstruction. But when it comes to acute mitral regurg, the valve just opens like this and the blood is continuously flowing, so you don't hear a murmur. You hear a murmur when it's chronic in nature. So what are you going to do when you suspect it? It's an emergency, you do a bedside echocardiography that's going to show you that there's regurg going on. When it comes to acute, it's an emergency. When it comes to chronic, it's not. So when you decipher that it's acute mitral regurg, you have to perform an emergency surgical intervention. Mitral valve prolapse is the most common cause of mitral regurg in developed countries. MVP occurs due to myxomatous degeneration of mitral valve leaflets. It's a really high yield, really, I can't stress that enough. It's a really high yield line. MVP is caused by myxomatous degeneration of the mitral valve leaflets. You need to memorize this. It usually causes mild MR with mid-systolic click. Patients with severe leaflet dysfunction and prolapse can eventually develop severe mitral regurgitation and hollow systolic. So, mitral valve prolapse leads to mitral regurg, but initially the regurg can be really mild, but eventually it becomes really prominent, and you can hear a hollow systolic murmur throughout the systole. So, we'll move on to the primary types of mitral regurgitation. So there is a primary mitral regurg, or there's a mitral regurg secondary to another cause. Primary mitral regurg occurs when there is problem with the mitral valve itself. For example, like mitral valve prolapse due to myxomatous degeneration of the valve can lead to mitral regurg. That's a primary cause. So secondary cause of mitral regurg, as I told you about, acute decompensation of the heart failure results in the mitral valve annulus dilation, and displacement of the papillary muscle results in taut stretching of the mitral valve chordae tendineae, the tissue on which the mitral valve. Okay, so this results in acute mitral regurg as a result of dilation. I'll draw it here for you guys as well. So if you visualize that this is the mitral valve annulus and these are the mitral valve cusps, so and this is the left ventricle, this is the right atrium, this is the right ventricle, and this is the right atrium. So when there's decompensation, the structure of the left ventricular specifically becomes like this, and there's a marked dilation of the mitral valve annulus where the mitral valve cusps are held into place. So the cusps don't change in size, but the annulus does. So when this happens, the closure or the approximation is not complete, and during ventricular contraction this results in backflow of the blood, aka mitral regurg. So this is the mechanics of how this works. treatment of decompensated heart failure that results in mitral regurg is to reduce the amount of blood that is present in the left ventricle. And how are you gonna do that? You're gonna reduce the preload, you are gonna reduce the afterload. And how do you do that? You do that with the help of diuretics and venodilators. When you do this restores previous because during heart failure there's also fluid retention throughout the body. So if you give diuretics and reduce the overall circulating volume, that also results in decrease in the preload. And if you give nitroglycerine and venodilators, that also results in decreased venous return. And if you give arterial dilators, that also results in reduced systemic vascular resistance, which also further improves the strain on the failing heart. That results in reduced left ventricular and systolic volume, thus thereby returning the mitral valve annulus to its original size, and that leads to the resolution of the secondary mitral regurg. So this is also an important concept, and this how it's going to present is like a patient with a known history of heart failure is going to present with pulmonary edema, and you might assume that that pulmonary edema is due to the heart failure, but they also give you a finding of the fact that the echocardiogram shows severe regurg, and they might ask you a reason for that. So the reason is due to the dilation of mitral valve annulus. So that is the reason. So they may tie in heart failure to this aspect of mitral regurg. So there is acute mitral regurg, everything that we discussed just here, and there is compensated chronic mitral regurg or decompensated chronic mitral regurg. So these are some important factors pertaining to each one of them, and I'm going to explain how you can easily decipher which one is which. So you don't have to consider the double arrows, or you just need to consider the which arrow points towards increment, that is upwards, and which one points towards the decrease. So in acute mitral regurg, what is gonna happen to the preload? What do you mean by preload? By preload we mean the amount of blood volume coming from the left atrium. Let me just draw it, that's gonna make some visual as well. So this is the heart, these are the four chambers, and the blood in the left atrium, LA, is referred to as preload. So in acute mitral regurg, what is going to happen to this preload? What's going to happen is when the ventricle contracts, all the blood, because there's acute regurg, is going to go to the left atrium. So the preload, that which is the left atrium pumping towards the left ventricle across the mitral valve, is gonna be markedly increased. So what is gonna happen in case of compensated chronic mitral regurg? It's gonna be the same, obviously, because there's a small regurg of blood with every systole into the left atrium. So the preload, that is the blood in the left atrium, is gonna be increased in both acute and chronic mitral regurg. It's going to be more in acute because a lot of blood would go into the left atrium, and the left atrium is not well compensated, so the blood pressure in the left atrium is going to be greater in acute, and mitral regurg going to be a little bit less in chronic, but nonetheless preload is going to increase in both of these cases. Decompensated chronic mitral regurg, obviously it's regurging to the left atrium, so preload is also going to be increased in that. What do you afterload? Let's come to the afterload. What do you mean by afterload? Afterload means the amount of resistance against which the left heart is gonna pump blood. So in acute mitral regurg, there's severe dilation, that too in an acute way, and there's no compensation being done. So the ventricle left ventricle has two options. It can pump the blood towards the aorta. I'm gonna draw it like this, or it can pump the blood back towards the left atrium. And since now it has two pathways of pumping blood, either to the either to the aorta or to the left atrium, and the left atrium pathway has been acutely opened, and it is not compensated suddenly, so the afterload is gonna reduce. Afterload is basically the resistance against which the left ventricle is pumping blood. So the left ventricle now has less resistance because it has two pathways of pumping blood. The resistance is gonna be less because it can also pump blood towards the aorta and also towards the left atrium. So the afterload is reduced in acute mitral regurg. In compensated chronic mitral regurg, what happens is that since the dilation or the regurg slowly happens and the atria compensate for the increased amount of blood volume that is being sent towards the left atrium, the afterload is not that much affected because there's compensation going on. The resistance against the aorta, it's the same, and the resistance against the blood flowing from the left ventricle to the left atrium, it also remains the same because there, for example, you can consider like if this is acute regurg, this is the amount of opening that is in acute regurg. It's like a full open house. But when it comes to chronic regurg, chronic compensated regurg, this is the only amount of blood that is being that is regurgitating back into the left atrium. So the afterload is not that much affected because of the fact that the amount of pathway, the alternate pathway is not that much big. This is the pathway that happens in acute. A lot of blood can flow, but when it comes to chronic, it's compensated, not that much blood. The main amount of resistance is coming from the aorta, and the blood flowing back to the left atrium is minimal. So there is no change in the afterload. When it comes to decompensated chronic mitral regurg, it's decompensated. It's just like decompensated chronic mitral regurg. Afterload. What is going to happen to the afterload when the heart or the regurg decompensates? So this is the reason for no change in afterload in compensated chronic mitral regurg. One more thing is that in acute mitral regurg, no, it's not one more thing, just that in acute mitral regurg, the outflow is greater, so the afterload is reduced. Whereas in compensated chronic mitral regurg, the outflow is not that much, so there's no change. In decompensated chronic mitral regurg, the afterload is increased. Now the question is, why is the afterload increased in decompensated chronic mitral regurg? The reason is that the left atrium is overfilled with blood because the mitral because it is decompensated, and due to the overfilling of the left atrium with blood, now the left ventricle has to pump blood against the systemic vascular resistance in the aorta as well as the overfilled left atrium. So this is the reason why the afterload becomes markedly increased in chronic decompensated mitral regurg. The question is, why does the afterload not increase in acute mitral regurg? The reason is that because there is ability to accommodate blood in the pulmonary vasculature. But when it comes to chronic decompensated mitral regurg, the pulmonary circulation is already filled with blood, and the left atrium is already filled with blood, and the decompensation results in overfilling of all these structures. So the resistance becomes really a lot. Resistance against the flow of the mitral regurg and resistance across the aorta combined result in a greater afterload. Whereas in acute mitral regurg, the left atrium firstly overfills, then the blood backs up into the pulmonary circulation, then it overfills. So it's a time taking process. That's why the afterload, immediately there's reduction of the afterload, but chronically when it's decompensated there is increase because all the structures are already filled to the max. So the contractile function, it's of the left ventricle, this is what there is not going to be any change. And in compensated chronic, there is not going to be any change because it's compensated. The left ventricle has undergone eccentric hypertrophy in this case. So but in case of decompensated chronic mitral regurg, contractile function has been decreased. The reason it has been decreased because obviously it's decompensated. What do you mean by compensated? What we mean by compensated is that despite the fact that the mitral regurg is going on, there is enough and sufficient blood being pumped into the aorta. Decompensated means that enough and sufficient blood is not being pumped through the aorta towards the body because the heart is has given up. So the contractile function has decreased. Ejection fraction and forward stroke volume. What is the difference between ejection fraction? Is the amount of blood that is moved when the ventricle contracts. It is not dependent on where that blood goes. If the blood goes in back into the left atrium, we don't give a fuck. If the blood goes into the aorta, we still don't give a fuck. As long as the blood is leaving the left ventricle, it is considered in ejection fraction, whereas forward stroke volume represents only the amount of blood that moves into the aorta towards the systemic circulation. So the ejection fraction in case of acute MR is increased. Why? Because the blood because greater amount of blood is now leaving the left ventricle. Why? Because it is going through the less resistance pathway back to the left atrium as well as into the aorta. So the amount of blood that is being ejected from the left ventricle is increased in case of acute mitral regurg. Why? Because a less resistance pathway of the mitral valve has now also formed. So there are two pathways for the blood to flow back to the left atrium and into the aorta. So that's why overall the ejected blood fraction of the ejected blood is greater. When it comes to forward stroke volume, that is reduced. Why? Because the pathway to the left atrium has less resistance, so most of the blood flows back into the left atrium and less of it goes to the systemic circulation. That's why the forward stroke volume decreases. But if this becomes compensated mitral regurg, what's going to happen? What do you mean by compensated? That the body is being compensated. That means the left ventricle has hypertrophied, has undergone eccentric hypertrophy enough so that it can pump adequate blood into the aorta. So ejection fraction is still going to be greater because the blood is going through two pathways, but the blood that is being supplied to the aorta for the systemic circulation is going to be stabilized and be compensated. So there is going to be no change when the left ventricle compensates via eccentric hypertrophy. When it comes to decompensation, obviously forward stroke volume has been reduced, not enough blood going towards the body, and the ejection fraction has also now been reduced. Why? Because the left ventricle has given up. It is not ejecting blood. It does not matter whether it's to the left atrium or to the aorta. It's not ejecting the amount of blood that it used to, because now it's failing. Plus the forward stroke volume, it is not even ejecting blood to the aorta as well. So both of these factors decrease here. So the ability to differentiate between all these acute compensated and decompensated chronic mitral regurg, that's really important. So let's give it a read as well. In acute MR, there's a sudden onset large volume backflow. Let me just erase everything. In acute, there is sudden onset large volume backflow of blood to the left from the left ventricle to the left atrium, because the large volume and rapid equilibration of left ventricle and left atrial pressure, both of the left ventricle and left atria develop the same pressure because equilibrium develops. The associate murmur is often one more high yield thing. In acute mitral regurg, the sound of the murmur won't be that audible. The reason is that because this is the amount of gap in acute mitral regurg, so there's not going to be any turbulence, so you won't be able to hear a murmur. But when it comes to chronic compensated, you're going to be able to hear a murmur because now the blood is going to be turbulent in its flow because of the narrow opening. So I also wanted to mention this point as well. So absent, unlike in chronic MR, the clinical features primarily reflect the heart chamber's lack of time to adapt. The left atrium won't be able to adapt, and the left ventricle won't be able to adapt as well. The left atrium has inadequate time to stretch to accommodate the increased blood volume and remains normal in size. The consequent increase in left atrial pressure is transmitted back to the pulmonary circulation, resulting in pulmonary edema. The left ventricle receives increased blood volume from the left atrium with each diastole. This results in increased left ventricular and diastolic pressure. The ejected blood can flow either forward through the aortic or backward to the relatively low resistance pathway to the left atrium. It can flow in both directions. That's why the ejection fraction increases, but the forward stroke volume that also decreases because more of the blood is going towards the left atrium. Although absolute volume of the forward blood flow, cardiac output is decreased. Total stroke volume, not forward stroke volume, total stroke volume, which is basically the ejection fraction, is increased, resulting in normal or hyperdynamic left ventricular ejection fraction. So the ejection fraction increases, but the forward stroke volume, which represents the blood in the aorta, decreases. When it gets compensated, it normalizes, but ejection fraction remains high because two pathways are present for the forward flow. Chronic MR allows time for compensatory atrial stretch. So chronic MR allows time for compensatory atrial stretch, as I told you guys, to accommodate the extra regurgitant blood volume at the lower filling pressures. In addition, the volume overload left ventricle undergoes eccentric hypertrophy to compensate for to temporarily maintain cardiac output. Because of this eccentric hypertrophy is the fact that the forward stroke volume does not change because the heart compensates for that. That's the reason. However, decompensated overwhelming wall stretch eventually leads to left ventricle contractile dysfunction and decompensated heart failure. Eventually, the heart does give up, and when it does, we have these markers here, which are represent decompensated chronic mitral regurg. Forward stroke volume decrease because heart ain't working. Ejection fraction also decrease because the heart ain't working. Contractile function also decrease because the heart ain't working. Afterload is increased. Why is the preload? Preload is also preload is already increased because with each regurgitation, the next diastole is gonna bring more blood to the ventricles. So the preload is increased. Afterload, why does the afterload increase? The answer to that is because now everything is overfilled. I told you guys earlier, the left atrium is fully filled, the pulmonary circulation is overloaded. That's why the afterload is increased. Whereas when it comes to acute MR, because things are all filling slowly and they are getting overloaded, so in acute MR the afterload is decreased. Surgical indications for chronic mitral valve regurg. So surgery if left ventricular ejection fraction is 30 to 60%. The normal left ventricular ejection fraction is 50 to 70. So if it falls between 30 to 60, regardless of the symptom, what is the reason behind this? Left ventricular ejection fraction represents the overall blood volume flow, regardless of where it's going. It includes the both flow back to the left atrium and to the aorta, both of them. So if it's 30 to 60%, that means since you have to divide the blood, majority of the blood will be going into the left atrium and less of it would be going into the aorta. So that means if there's a left ventricular ejection fraction of 30 to 60%, that means the aorta is being deprived of the blood flow. It's simple because the blood is going into two directions now. If it's at 70% ejection fraction, we can assume that it's good because aorta would be getting blood. But 30 to 60, that ain't sufficient enough to provide blood to the body because you're pumping blood to two areas, one towards the left atrium and one towards the aorta. So if you have this, regardless of symptoms, you don't need to have any symptoms of hypoxemia or anything like that, of pulmonary edema. You go for the surgery. Consider surgery if successful valve repair is highly likely. For symptomatic patients, ejection and left ventricular ejection fraction less than 30, you do surgery. For asymptomatic and left ventricular ejection fraction greater than 60. Secondary mitral regurgitation, the one that happens when there's decompensated heart failure, you don't need surgery, you just do medical management for the heart failure and things get better. Primary mitral regurg is that caused by intrinsic defect of the mitral valve. They'll say hours to days after an MI, patient has new onset systolic murmur. What's happening here? Rupture of the rupture of the papillary muscles resulting in acute mitral regurg. So that's why you have a systolic murmur after an MI. The answer would be mitral regurg. That's a really high yield question as well. Seen acutely in acute rheumatic disease, valve scars over years and becomes stenosed later. In a mitral, in rheumatic heart disease, firstly you get the regurg, then the patient develops stenosis as the valve scars. So the main thing that you need to remember here is that you perform a surgery if the left ventricular ejection fraction is between 30 to 60%. You don't need to give a fuck about the symptoms. If this is the case, you do the surgery. So the next in line we have aortic regurgitation. So where is the sound of the aortic regurgitation heard? As we did the mnemonic A and P regurg, T and M. So at the A and P regurg line is where you're gonna hear aortic regurg. So what is the most common reason behind aortic regurg? It's a congenital aortic bicuspid valve. The bicuspid valve is not competent enough, so it leads to aortic regurg, and after the calcification it turns into aortic stenosis. Rheumatic heart disease also leads to aortic regurg, and then it follows aortic stenosis. 10 years prior to stenosis you'll have regurg. That is the usual timeline. Aortic root dilatation, that happens in Marfan syndrome and syphilis. So that this is also important one. So usually you might get an MCQ of a person with a Marfanoid habitus, and that person, if the Marfanoid habitus is not that, I'm also pointing out all the questions. If the habitus is not, if it's a child, the Marfanoid habitus won't be that prominent, or they may just mention that the person just from fell from the stairs, or it might not, it might be a really small trauma and the person has dislocation of the lens, and you might consider, oh my god, such a small trauma leading to dislocation. And the other feature they might also highlight in a child is high myopia. The child might have a number of 6 or 7, and when he fell down and you just viewed the iris, you saw that the iris was really jiggly. When you asked the patient to move the eye, and you observed the iris was jiggly. What's the reason? That's termed as iris stress tremulousness. What's the reason behind the iris being jiggly? The reason is that the lens posterior to the iris has been dislocated, and when the person moves the eye, or when the person moves the pupil around and the eye moves, the posterior lying dislocated lens just wobbles the iris muscles. That's why the iris seems jiggly. So that's what you're going to see in a child, and if it's an adult you might see the Marfanoid habitus, and they'll ask you what's the next best step. The next best step would be to perform an echocardiogram to analyze for the aortic root dilatation. That's a really important question here. Why? Because aortic root dilatation can lead to aortic regurg insufficiency and can eventually also lead to aortic dissection. So this is an important point that I wanted to highlight. Everything ties with each other really well. So the reason behind this lecture is to compile everything together. Backflow from the aorta. So what happens during regurg? After the systole, when the ventricle contracts, let me just demonstrate it as here as well. So this is the heart, and this is the outflow tract for the aorta. This is the atrium, and this is the mitral valve, and this is the aortic valve. So when the ventricles contract and the blood flows through the aorta, when the ventricles start relaxing, there's regurg of the blood back into the ventricle. That leads to greater amount of left ventricular and systolic volume. With each systole there's greater amount of blood left after the systole. So this leads to progressive blood overloading of the left ventricle. And what type of hypertrophy is going to occur because of greater amount of blood? That's eccentric hypertrophy. So this eventually leads to eccentric hypertrophy, and eventually, because there is stress on the left ventricle, the heart starts to fail. And initially the heart compensates well, but eventually it starts to fail. So this is how aortic regurgitation can be life threatening because of eventual heart failure. So what is the murmur gonna sound like? It's really easy to decipher what the murmur is gonna sound like, and I'll show you that with the help of another diagram. So this is the left ventricle, this is the right ventricle, this is the aorta that's branching, this is the valve, aortic valve, this is the atria. And so when the ventricle is contracting, the blood is flowing forward, so you won't be able to hear any murmur. When the contraction is complete and the ventricle starts relaxing and diastole begins, that is saying early diastole, when the ventricles stop pushing the blood forward and the blood starts backing up against the aortic valve. Normally the valve won't allow any backflow, but since the valve is incompetent, there's a sudden gush of blood back into the ventricles. Why is there a sudden strong gush of blood in the start? The reason is that the maximum amount of blood is pooling at the start, and as the blood regurgitates and the ventricle starts to fill, as the ventricle fills completely, the regurgitation of the blood slows down because the ventricle is already full. So the regurg is maximum at the start when the ventricles are empty, and slowly it goes down. So the voice is going to be maximum at the start and it slowly tapers down. What is this called? This is decrescendo. So the murmur is going to be early diastolic decrescendo murmur, and it occurs during diastole, early diastolic decrescendo, decrescendo diastolic murmur. You can say early diastolic decrescendo, it's the same thing. So one more thing, as I told you, what is gonna happen to the diastolic blood pressure? The systolic blood pressure is gonna be the same. It's gonna be like in a normal person, it's gonna be 120. The diastolic blood pressure, however, because of the rapid regurgitation of the blood back into the ventricles, it's not gonna go back to 80 like it does in a normal person. It's gonna fall way back. It's gonna become 50. So the pulse pressure is gonna get widened. Why is there widening of the pulse pressure when it comes to aortic regurg? Because of exaggerated drop in the diastolic blood pressure due to the regurgitation of the blood. So in opposite to that, what happens in this is where there is widening of the pulse pressure. There's another case when there is narrowing of the pulse pressure. That was when there is a drop in the systolic blood pressure. What was that? That was aortic stenosis. Yes, that's right. What's going to happen in stenosis? The maximum systolic blood pressure would be reduced because of the obstruction caused by the aortic valve, and the systolic blood pressure won't be able to hit 120. It'll just hit 100 because the obstruction is being caused by the aortic valve. However, the diastolic blood pressure would be normal. It's going to be 80. So that would result in a narrowing of the pulse pressure. I just wanted to highlight that as well because things are interconnected, and if you make sense of everything, it's going to stay put in your memory for a longer time. So aortic regurg, widening of the pulse pressure due to exaggerated drop in the diastolic blood pressure. Aortic stenosis, narrowing of the pulse pressure due to the drop in systolic blood pressure. So what is the pulse gonna sound like? The pulse is obviously gonna be water hammer pulse. The systolic blood pressure goes to 120, it doesn't drop to 80, it drops to 60. So it feels like something just went up and suddenly went down. So this is termed as a water hammer pulse. If you strike, if why is it called a water hammer pulse? It's called a water hammer pulse because if this is a uh, water pipe and you strike it with a sledgehammer here, it's gonna cause a wave to form that's gonna travel forward. So this is what the pulse feels like in aortic regurg. There is a rapid systolic impulse followed by a rapid drop. The reason behind that is because the blood regurgitates back into the left ventricle and there's a sudden drop. So this is why it's called a water hammer pulse. Pistol short femoral pulses, it's the abrupt carotid distension and collapse. It's the same as I showed you here. Abrupt rise and then collapse. It's like a wave is just following forward. So now let's just give it a read. I explained everything really logically and well. You can make sense of almost everything. Widened pulse pressure because of increase, because of exaggerated decrease in the diastolic blood pressure. You just need to keep this one in mind when it comes to stenosis. There's a drop in the systolic blood pressure, and regurg, there's a drop in diastolic blood pressure. Rapid rise and rapid fall, water hammer pulse, the way of traveling. Keep that in mind. Abrupt carotid distension and collapse. The most common cause of AR in developing countries is rheumatic fever. After that, it initially presents with regurg. After that, stenosis. Developed countries is often due to, in developing countries it's AR, in developed countries it's aortic root dilatation or congenital bicuspid valve. These are both the reasons that also the dilation leads to dilation of the annulus. So regurg happens, congenital bicuspid, it's incompetent, so the regurg happens. Although frequently associated with aortic stenosis, bicuspid aortic valve is the most common cause of AR in developed countries. Initially, it presents with regurg and stenosis develops later. Patients with aortic AR due to bicuspid aortic valve typically diagnosed in the 30s, 40s, and age 10 years lower than that at which AS due to BAV presents. AS presents 10 years later. I told you guys. Initially, it's going to cause regurg. After 10 years, the stenosis would happen due to calcification. The aortic regurg can be asymptomatic or cause palpitations. Why can it cause palpitations? Because of the water hammer pulse. The systolic impulse can be really felt by the person, so it feels like palpitations. Chest pain and dyspnea, that's not high yield. The best way you're going to be able to diagnose is by being aware of the features of the murmur, its location, and the quality of the pulsation. That is water hammer pulse, rapidly rising and falling carotid pulses, and the location of the murmur, and that the murmur is diastolic in nature and the murmur is loud at the start, gets softer at the end, that is decrescendo. This is what's going to help you, not the symptoms. And a history of AR, or a history, and if you know that the person has Marfan syndrome, that can maybe help a little bit, but mostly the characteristics of the murmur are going to help you do everything. Pulses by Ferencz refers to two strong systolic peaks of aortic pulse from left ventricular ejection separated by a mid-systolic dip. It can be palpated in patients with significant aortic regurg with or without aortic stenosis, or hypertrophic obstructive cardiomyopathy, and occasionally large patent ductus arteriosus. So we come towards bicuspid aortic valve is sometimes associated with aortic root dilatation, which can also cause aortic regurg. With aortic regurg due to root dilatation, the murmur is best heard at the right upper sternal border. We're gonna come to that mnemonic again, the A and P. As I told you, A, P, A and P regurg. This is T and this is gonna be M. So, as I told you, A and P regurg are here, and this is aortic stenosis, and this is aortic regurg. And I told you guys earlier, if the aortic stenosis is due to supravalvular stenosis, it's gonna be even. This is the sternum. It's gonna be even above the aortic stenosis area. It's gonna be in the first intercostal space. So the same goes for aortic regurg. If the aortic regurg is due to the valve, it's going to be at the A and P regurg area. But if the aortic regurg is due to aortic root dilatation, it's going to go to this side. And where? At the aortic area or above the aortic area. So basically, you just need to remember that aortic stenosis due to valve is going to be at this aortic area. If it's due to aortic supravalvular or aortic narrowing, it's going to be here. And if the regurg is due to the valve, it's going to be at the NP regurg area. Otherwise, it's going to move to the right side. So this is one more thing. So the difference, you just need to keep the difference in mind. The difference is quite unique, but if you remember the mnemonic carefully, it's going to be easy for you to remember this. So let's clear it out. And right upper sternal border, yeah, it moves from the A and P area, which is on the left side, to the right side, reflecting the turbulent blood flow across the aortic root. Aortic root dilatation can progress to aortic aneurysms and dissection, sometimes causing sudden death. That's why people with Marfan and Ehlers-Danlos are, you do an echocardiography just to make sure and keep in check the aortic root dilatation, because that is the major cause of morbidity in such patients. So let's move on to mitral stenosis. Rheumatic heart disease, vast majority of cases initially causes rigor, late it causes mitral stenosis. The age-related calcification. So the main one is just the rheumatic heart disease. So what is mitral stenosis? Just like aortic stenosis is a really big bummer. That also causes a lot of problems. So one really weird finding about that is postnasal drip and hemoptysis. So why? How does mitral stenosis cause hemoptysis? So what mitral stenosis does is it causes backing up of blood into the pulmonary circulation. If the pressure rises a lot, and if the stenosis is really hard, some of the few minor pulmonary vessels they might burst, and they might cause leaking of small amount of blood. That is when you cough, it is evident as hemoptysis. So it's a really weird finding about mitral stenosis, but you need to keep this hemoptysis in mind, because sometimes people confuse it with a lung pathology, whereas it is a primary valve pathology. And I also explained the mechanism. You might say, what? Why is the hemoptysis happening? It's happening because the pressure backs up and breaks the vessels in the lungs. Exertional dyspnea, obviously, the heart won't be receiving that much preload properly and won't be able to pump that much blood adequately. Plus, the pulmonary edema due to the blood backing in the lungs would also impair oxygenation. So, mitral stenosis, the blood backs up, and what is mainly affected is the right ventricle, and the right side of the heart starts to fail. So this is how mitral stenosis affects. So we have the heart. Oh, so aortic rigors. We come back to, so we have the heart here. We have the heart here, and this is stenosis. So the blood is gonna back in the lungs, and back from the lungs, the blood is also gonna back in the right ventricle here. So pressure is going to be up here, pressure is going to be up in the pulmonary veins, the pressure is going to be up in the pulmonary capillary wedge pressure, that is the capillary bed in the lungs. The pressure is going to go up in the pulmonary artery, and the pressure is going to go up in the right ventricle and in the right atrium, and you might even see jugular venous distension. So the arrows here are really important, because that is how you decide that it's not a left ventricular issue, it's basically a mitral issue backing up. So the pressures in the chambers in the pulmonary artery and the veins, and the pulmonary capillary wedge pressure, which is the capillaries in the lungs, that is how they are really important. So you're going to get a lot of questions where these pressures are given and you're asked to decipher the reason behind that. So mitral stenosis, one more thing that the mitral stenosis does is, because of the backing of the blood in the left atrium, the left atrial dilation happens. And you guys know what happens when a chamber dilates. There are more chances that the arrhythmia can occur because of a larger surface area of the chamber. The impulse can go around, and before it completes a rotation, the starting point might get repolarize and ready for another depolarization, and the cycle might get vicious, and the impulse might start to depolarize in itself without any stimulation. So that can lead to atrial fibrillation. And the main reason behind atrial fibrillation is dilation of the left atrial chamber. And as I told you, the impulse travels, and when once it reaches the starting point is ready for another depolarization, because the chamber is so long and takes more time to complete the depolarization. And take might take so much time that the repolarization happens at the starting point. So the impulse just keeps going evolve, and that leads to atrial fib. So the sound is gonna be, the murmur is obviously when the atria contract. That is when you're gonna be able to hear a murmur. So it's gonna be diastolic, and you will be able to hear an opening snap, and the sound would be at the apex at the mitral area. Echocardiography would show increased transmitral flow velocity. Why would you get increased velocity? Because the aperture from which the blood is flowing is really narrow and stenosed. So obviously, if the blood blood is flowing through a bigger pipe, the blood is gonna the amount of blood flowing would be more, but the velocity would be less. But if it's flowing through a narrow pipe, the amount of blood volume flowing through the pipe would be less, but the velocity would be more. So the same mechanics apply here. Treatment. So balloon valvulotomy or balloon dilation. So percutaneous valvulotomy or surgical repair. Basically, they do a balloon valvulotomy where they push a balloon inside the mitral area and open it, expand it, and that relieves the stenosis. Long-standard MS can lead to left increase in left atrial pressure, which in turn lead to pulmonary increase, pulmonary pressure, pulmonary vascular congestion. These changes can cause dyspnea, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, and can eventually lead to right heart sided failure. So how is the patient going to present? The patient is going to present, is going to say he had a history of shortness of breath for a long time, and now the patient is having more trouble, as in he cannot sleep without putting three or four pillows behind his head. This represents that the lungs are filled with water, and when you lie supine, it becomes more congested. This is termed as orthopnea. Though the patient might complain that he needs more pillows to sleep, the patient might also complain that he has small amount of blood in his cuff and sputum. And when you observe, the JVD might be raised, and then the magic happens. You just observe for a murmur, and once you see a murmur at the mitral area, it's really easy to make a diagnosis, especially when it's diastolic in nature. So, a diastolic in nature murmur at the mitral area with a patient saying that he has symptoms of heart failure. It's simple. And difficulty breathing. It's simple. You'll be able to make a diagnosis. But you just need to keep in mind that the lungs would be congested, the JVD would be raised, the right side of the heart would be failing, and the patient will also have dyspnea because there's improper oxygenation and all that good stuff. So, rheumatic mitral stenosis is an insidious progressive disease. Patients can remain most asymptomatic for years. During pregnancy, however, so what happens during pregnancy? What happens during pregnancy is as the circulation becomes hypervolemic, there's a lot of fluid retention in the body, and the requirements for oxygenation also increase. So when this happens and the body requires more blood to flow through the chambers, that is when asymptomatic mitral stenosis becomes symptomatic. So a patient might be totally fine, and once the patient gets pregnant, after 1 or 2 months, they start noticing symptoms of dyspnea, a shortness of breath, and orthopnea, and you hear a murmur at the mitral area. You know what's wrong. The patient already had stenosis but was asymptomatic, but now the requirements have increased and the patient has become hypervolemic, and now the small amount of stenosis that was previously being unnoticed is causing a lot of trouble. During pregnancy, physiological increases in heart rate and blood volume raise the transmitral gradient left atrial pressure at rest, and during, as seen in this patient, these changes often precipitate symptoms of fatigue, exercise intolerance, and dyspnea in previously asymptomatic patients with rheumatic mitral stenosis. The patient had stenosis, he was fine. She got pregnant, she's fucked. So that's why mitral stenosis is a contraindication to getting pregnant. Aortic stenosis is also a contraindication to getting pregnant. So these two things you need to remember really clearly. If a patient has any of these, you ask the patient to not get pregnant. These patients are also at increased risk of developing AFib. Why? Because of increased pressure in the left atria, the left atrial dilation becomes more exacerbated during pregnancy. The loss of an effective atrial kick decreases the diastolic pressure, diastolic filling time seen with AF, and further increase left atrial pressure and domestic worsening. So, this patient can get fucked in a lot of different ways. So, a patient with previously asymptomatic mitral stenosis, if that patient gets pregnant, the mitral stenosis becomes symptomatic. You quit that case, let's discuss another case. If the patient had mitral stenosis and that patient was asymptomatic, and now that patient, it's not, I'm not talking about a pregnant patient, I'm talking about a male. He had asymptomatic aortic stenosis, and now that patient develops atrial fibrillation. He's also going to get symptomatic now. So these are two different things. They can happen in a pregnant patient as well. Like a pregnant patient becomes symptomatic due to getting pregnant, and then the patient also develops aortic atrial fibrillation because of left atrial dilation, he's gonna get even more fucked. And why do the patients get deteriorated or bad when they develop atrial fibrillation is because usually there's a passive blood flow from the atria to the ventricles during the atrial filling. The atria are just filling, they're not contracting, and the blood is still going to the ventricles. So, if a person has mitral stenosis, uh, it's highly possible, and the person is asymptomatic. What's happening right here is that even though there is no passive filling because the mitral valve is stenosed, but whenever the atria contract, they do allow the blood to move to the ventricles. But if the atria develop fibrillation and there is no coordinated contraction anymore, so what happens? Simple. The mitral valve is already stenosed. There is no passive blood flow during the filling of the atria, and now the atria are not even contracting. What's gonna happen? Obviously, the patient's gonna get really fucked up because there's no blood in the ventricles to be pumped forward. So, for those of you who are not that good at making sense of the audio, I'll also give you a diagram here. So this is the heart, these are the four chambers. Usually this is the mitral valve. Usually when the atria are filling, there's a passive blood flow to the ventricles. But if this mitral valve gets stenosed, the blood filling of the ventricles is now totally dependent upon the atria contracting. This is termed as the atrial kick. There is also passive filling, but the atrial kick moves most of the blood into the ventricles. So if the atria develops fibrillation and the person already had stenosis, is there's no blood going forward into the ventricles, so he's gonna become extremely symptomatic. So this can happen in a pregnant patient. What I mean to say, these are different cases, but they can happen in the same patient as well. Patient became pregnant, became symptomatic became symptomatic, then also developed AFib, then the patient is fucked. Okay, mitral rheumatic mitral stenosis, an insidious progressive disease, and physiological hemodynamic changes during pregnancy can precipitate symptoms in a previously asymptomatic patients. This is what we were discussing. The development of new atrial fibrillation can further fuck the patient, further increase transmitral gradient and left atrial pressure with dramatic worsening of pulmonary congestion. The patient is gone now. Atrial fibrillation can induce acute decompensated heart failure in the setting of mitral stenosis because many patients with mitral stenosis already require the additional left ventricle filling supplied by the atrial contraction. Patients, what's the summary? Patients with mitral stenosis are dependent on atrial contraction. I'll write that down as well for you guys. So as you guys can see, I just added it here. Summary: patients with MS are highly dependent on atrial contraction. In case of AFib, the patient get decompensated heart failure. So atrial fibrillation in the setting of MS also carries even a higher risk of thrombogenic risk than non-valvular atrial fibrillation, and the routine anticoagulation with warfarin is indicated regardless of CHADS VASC score. So what is CHADS VASC score? CHADS VASC score is a score that you calculate in order to decide whether you're going to put a patient on anticoagulation or not. We're going to discuss that further as well in the other chapters, but this score becomes irrelevant when there is atrial fibrillation plus mitral stenosis. So this is also a takeaway point. I'm going to also add it in some. So I've written it here. No chat best score needed if AFib plus MS. So you're just going to put the patient on anticoagulation. If it's just atrial fibrillation, you're going to calculate the chat's best score first. And if it indicates anticoagulation, then you're going to start it. 99% of mitral stenosis are due to history of rheumatic heart disease. Yeah, that is the patient had rheumatic fever as a child, where at that time it was mitral regurg, but years later it has now become mitral stenosis. Pregnant woman with new onset dyspnea in the second trimester in a diastolic murmur. Yeah, this is really high yield. That's why I've also added it in the notes. So this is a high yield question. Pregnant woman with new onset dyspnea in the second trimester, especially when the requirements become really high and the circulation is hyperdynamic, and a diastolic murmur at the apex. You know what it is. This is because 50% increase in plasma volume by second trimester causes the underlying clinical mitral stenosis to become symptomatic. Don't confuse this with severe dyspnea and peripheral edema in the late third trimester, which is peripartum cardiomyopathy. So these are the two things that you need to keep in mind. Decompensation in the second trimester, that's with a diastolic murmur at the apex. You can go for mitral stenosis that has become symptomatic now due to hyperdynamic circulation. But if it's the third trimester and there are signs of heart failure, it's peripartum cardiomyopathy. That's it. And it's a really serious condition. And what do you do when this condition develops? We're going to discuss that in gynae, but I'm going to add it here as well. You're going to abort the pregnancy. If you can do a C-section, you go for a C-section. If you can deliver the baby, you deliver the baby. But you have to abort the pregnancy because it's a life-threatening situation. They're going to give you a scenario and they're going to ask you what's the next best step. Terminate the pregnancy or abort the pregnancy or get the child delivered or do a C-section, whatever you can. Just the pregnancy must be aborted. 2CK, balloon valvuloplasty. That is what they do for mitral stenosis. And here they write percutaneous valvulotomy or balloon valvuloplasty is the first line treatment for mitral stenosis. This is done if patient has minimal calcification of the valve, has pulmonary hypertension. Mitral valve replacement is done if balloon valvuloplasty fails. Okay, so the first choice would be balloon valvuloplasty. So when is this done? Balloon valvuloplasty is done if the patient has symptomatic mitral stenosis, simple as that. So we are going to move to pulmonic valve stenosis. So we know that it's gonna be heard at the P area, which is the left second intercostal space. Usually it is associated uh, with the tetralogy of Fallot. That is where pulmonic valve stenosis is usually associated with TOF. Congenital, usually isolated defect, rarely acquired. Severe right, what it's gonna do, it's gonna cause right heart strain because the right ventricle is under strain and lead to right heart failure. Symptoms, for example, in early adulthood, what is the quality of the murmur? It's gonna be same as aortic stenosis, crescendo, decrescendo, systolic ejection, and as I told you guys, valve stenosis leads to delayed valve closure, so the split would be widening, not fixed widening, widening, which would further widen during inspiration. But how are you going to diagnose echo, percutaneous valvulotomy, same as mitral stenosis? So one thing about that I need to mention here, it's if it's aortic stenosis, what do? You don't do valvulotomy or balloon valvulotomy. You replace the valve. If it's mitral stenosis, what do? You do a balloon valvulotomy. If it's pulmonic stenosis, you also do a balloon valvulotomy. Why am I revising this? Because it gets confusing. For aortic valve, you replace the valve. For mitral and pulmonic valve, you just do a valvulotomy. So I'm also going to add it here as well. So I just added it here as well. Valve replacement for AS, balloon valvulotomy for pulmonic stenosis and MS. Pulmonic valve stenosis usually occurs as a congenital defect and often remains asymptomatic until adulthood when the right heart gets really strained. Okay, atrial septal defect is a common congenital defect. It is asymptomatic at birth. That is the highest you thing that you need to know about ASD. It's asymptomatic. Is common congenital that leads to increased blood flow in the right side of the heart. Patient can have a mid-systolic murmur at the P and T area. Both it can be heard due to increased flow across the pulmonic valve. It also causes pulmonic flow murmur due to increased flow. So ASD would be associated with pulmonic flow murmur, which is an innocent murmur, which happens when there's more blood flowing across the pulmonic valve. However, it causes atrial septal defect. How are you going to catch it? First, the location. Second, fixed wide splitting. That's how you catch atrial septal defect.